Good evening, everyone. Thank you so much for logging on to this session, which is hosted by Indian Chess Society under the aegis of Dr. Samaria, Dr. Rajadhar, and our very dear Dr. Amita Nene, Madam. Now, this has been an initiative by the Indian Chess Society to further the education for the postgraduates, for the young physicians, and for elder physicians, whatever alike, and in a pursuit to just continue the medical education and keep everyone updated on what's the latest. Now, this specifically comes under the leadership of all these able people, and so many people have been helped, so many students have been helped. In fact, today's webinar is on special demand because last time also we had this particular webinar on progressive pulmonary fibrosis, and back on popular demand, I think we are back with the same thing. And this time around, we've tried to capture multiple more questions and doubts which were raised by the audience last time. So I think without further ado, I will like to introduce the speaker for tonight, Dr. Mehul. So Dr. Mehul Thakkar doesn't really need any introduction. Can we have Dr. Mehul's CV up there, please? So Dr. Mehul, yes. So Dr. Mehul is the director at Medan's Multi-Specialty Hospital, Mumbai. He is the former assistant professor at KM Hospitals, Mumbai. Also, Lokmanya Tilak Medical College, Sion Hospital. He has trained he has undergone training in intervention bronchoscopy at Cape Town under Professor Bolliger, who needs no introduction, and he's the honorary treasurer of the Indian Association of Bronchology. Under his command and with the whole IAB team, IAB has been touching multiple heights now, as everyone knows, in the pursuit of education for each and every one of us. So many thanks to Dr. Mehul for agreeing to take this talk. And without further ado, I would like to hand over to Dr. Mehul. Dr. Mehul, please go ahead.
Hi, thanks, Dr. Samir, for the kind introduction, and thank you, first of all, to the ICS team, Samaria sir, Rajadhar sir, and Amita Nene ma'am, to giving me the chance to speak in this webinar. Since this webinar has come in popular demand, I just hope I can do justice to the talk. I'm going to share my screen. So the talk given to me is a progressive pulmonary fibrosis, all that is you need to know. Now, a problem with such a talk is that there is so much more to know, and there are so many things evolving. Maybe if this talk is taken 2 years later, there will be many, many more things to be added. But I've tried to get whatever data is there up till now and try to simplify it for a better understanding. So this is just an introduction that we know what ILD is. It's an umbrella term for more than 200 type of diseases. All patients usually have progressive breathlessness, cough, impaired lung functions, imaging, you see diffuse palatal infiltrates, and patients have a reduced quality of life. Now, most ILD cases result from an etiological factor such as exposure to allergens, hazardous material, asbestos, drugs, or underlying autoimmune diseases. And this is how you can classify a diffuse or an interstitial lung disease, where you have just a native lung involvement, you have systemic disorders related, you have vascular disorders related, or exposure related ILDs. Where we are kind of focusing today is a form of ILD, which is for fibrosing ILD. The most common fibrosing ILD we all know is IPF, the idiopathic pulmonary fibrosis. It happens because of an unknown cause. It is seen in elderly population. You see on a CT scan UIP pattern, and usually the average lifespan of a patient varies from 2 to 5 years, or maybe in some cases a little longer, depending on how the patient behaves. Now, compared to IPF, the non-IPF ILDs are managed more effectively with a different treatment protocol of immunosuppressive therapies and have relatively less severe outcomes. So this is the whole chart of non-IPF ILDs, where you have IIPs, you have autoimmune ILDs, you have exposure-related ILDs with cysts and sarcoidosis. I will not be going into these details. Let's focus on the topic at hand, that is a fibrosing ILD. Now, fibrosing ILD, why this is something important to know, because these behave little differently. Fibrosing ILD refers to a group of lung disorders where there is presence of fibrosis or scarring within the parenchyma. The diagnosis overall of any fibrosing ILD will involve a combination of clinical evaluation. When you see a patient, you might do a CT or an X-ray initial on the first visit. You have a pulmonary function test and when necessary, a lung biopsy. Among ILDs other than IPF, a progressive pulmonary fibrosis refers to a specific form of fibrosing ILD that exhibits radiological signs of fibrosis and demonstrates evidence of progression over time. If you have a CTD related ILD or exposure related ILD, your immunosuppressions are going on and patient does not progress, that would not form under PPF. Approximately 13 to 40% of non-IPF fibrosing ILDs are expected to progress within 2 years, even if you manage them appropriately well. So is there a difference between a fibrosing ILD and a progressive pulmonary ILD or a fibrosis? Yes, a little fine line. A fibrosing ILD would be characterized by fibrosis detected on pathology or by presence of honeycombing traction bronchiectasis on a high resolution CT scan. Mind you, here the CT scan is done by ILD protocol with inspiratory, expiratory cuts and prone sections if needed. Usually we do a non-contrast scan in such patients. A PPF or a progressive pulmonary fibrosis denotes an ILD with radiological signs of fibrosis and evidence of progression over time. So how do you define progression? Is that some criteria? Yes, there is. This is an official joint statement by four respiratory societies which have said, and this is important, that in a patient of ILD of known or unknown etiology where there is no IPF, there is evidence of pulmonary fibrosis and there is progression if there is at least two of the following three criteria occurring within the past 1 year with no alternative explanation. So if you have a clinical worsening of symptoms, you have a clinical score which is worsening, you have physiological evidence. So it is either of the following: absolute decline in the forced vital capacity of more than 5% within the 1 year of follow-up, absolute decline in the DLCO for more than 10% predicted within the 1 year of follow-up, and any of the one or more of the radiological evidence of disease progression. That is, you have increase in extent or severity of traction bronchiectasis, new GGOs with traction bronchiectasis, new fine reticulation, increased extent and coarseness of reticular abnormalities, new honeycombing, and increased lobar volume loss. So you have clinical signs, physiological signs, and radiological signs, which taken together, you would define the patient as PPF. There have been studies which have looked at a 6 month, 1 year, or a 2 year definition for defining PPF. Most of the data which is coming is based on 1 year and 2 year, taking the 1 year and 2 year as a baseline of progression. But half a year, I would say, might be important in your clinical day-to-day practice. If you see patients within 6 months has an absolute decline of FVC of over 5% and worsening symptoms, even though you may not repeat a radiology at 6 months with no other explanation for deterioration, this patient could be a patient of PPF. So here, half-year criteria can be clinically relevant, but for most of the studies, 1 and 2 years is what is used. And which ILDs can progress to a progressive pulmonary fibrosis? This is the link where you can see all types: your chronic HPs, your NSIP patterns, your CTD ILDs, your drug-induced, few cases of sarcoid. All these undifferentiated ILDs all can progress, and this is there is no one ILD which you can think, okay, this will progress and this will not progress. Most of them can progress. So then, how do you determine which will progress? There are certain risk factors which you need to keep in mind. So there are some general risk factors. If you see a UIP pattern on diagnosis, if your BMI is on the higher side, if you have oxygen desaturation, which you find in the first visit itself, then these patients are more likely to progress. There are also disease criteria. Hypersensitivity pneumonitis of a fibrotic variant, you might see a decline of FVC of more than 10%. These will progress. If you have already low FEC at presentation, patient has come to you late, which happens in many of the metros. Patients go to a family practitioner, then they go to a physician, maybe a cardiologist for breathlessness, and then they reach the pulmonologist. The FEC could be declining faster. If you have RA-related ILDs, if you have a UIP pattern, higher levels of CCP antibodies, history of smoking, fibrotic score is high, extensive fibrosis is high, these patients will definitely more likely progress. Systemic sclerosis, if already has a low FVC of less than 65% when the patient is presented to you, or if you find a decline is faster, a high fibrotic score on a CT, and if you can determine the extent of fibrosis on the CT of more than 10 to 30%, these along with FVC of less than 70, these patients are more likely to be having a progressive form of fibrosis. So here there is some data that some form of ILDs progress more than the others, but all the spectrum that I showed you, anyone can progress. But if you have an autoimmune disease related ILDs, smaller number of patients progress in comparison to idiopathic interstitial pneumonias or HP, which is a fibrotic variety. So if you have an HP, these patients are more likely to progress. But for an individual patient, you have to look at the criteria that was mentioned. And the risk of mortality also differs between these ILDs which are progressing or the autoimmune related versus non-autoimmune related ILDs. So if you do suspect that this patient has a chance of progression and the patient has come to you with a fibrosing ILD, how would you investigate the patient? What is the initial minimum workup that you need to do? This is no news. All our patients usually go through all of these things. You first of all have to do a clinical evaluation and try to get an underlying ILD subtype. You do a basic CT scan, which is with an expiratory breath hold, prone images, expiratory images, and absence of contrast. When you're doing a high resolution scan, absence of contrast, because if you write contrast, they won't give you high resolution scans. Then you do pulmonary function test here at baseline. It is preferable to have the spirometry values and the DLCO and lung volumes so that we can check for any progression and also look out for other causes of breathlessness, which can include like a coronary artery disease. Patient may have, if a patient of systemic sclerosis has pulmonary hypertension, many patients, female specifically, could be anemic. Any other causes, if you have a pure vegetarian patient, low B12, as simple as that, that could be causing the breathlessness. So basic minimum workup depends on your clinical scenario. A CT and a full PFT is basic, which is needed. If you are suspecting or if you are faced with an autoimmune related ILD, these are the list of tests that you can do. Obviously, you won't do all the tests in all the patients based on the clinical scenario. You can choose, but you can go for evaluation of autoantibodies if you are suspecting autoimmune related ILDs. Would you do a biopsy for a fibrosing ILD in absence of a typical UIP pattern? The interventional procedures are case-to-case basis. If you have a good diagnosis with your serology or exposure history, and if your radiologist is confident this is probably going towards hypersensitive pneumonitis, you may not need a biopsy in these cases, but it should be done on case-to-case basis. Here, let me tell you, a patient who probably might progress in the next 2 or 3 years or next 1 year might have a decline of FVC. Patient is the center of your diagnosis. So you should take the patient into consideration where patient's choices are considered and patient's risk factor has been explained to the patient of doing or not doing a biopsy. Just having a scope and a cryoprobe with you does not mean you go ahead with a biopsy in these patients. If you do see or suspect a progressive pulmonary fibrosis, how would you monitor? If you have, forget, you have a patient in front of you who has come with a fibrosing ILD. Now, how will you monitor this patient? So what is recommended is PFTs at least every 3 or 4 months in the first 1 year. That's why I told you a 0.5 year or a half year cycle can be useful in a clinical setting where you want to see whether the patient is progressing in spite of your appropriate treatment and there is no other cause found to the deterioration. So if you have a pulmonary function test done at baseline, maybe repeat at 3 months, 6 months, 9 months. The 6 months or a 9 month PFT, if it shows deterioration of more than 5% of FVC at baseline, that means patient could be categorized as progressive pulmonary fibrosis. A serial CT, usually I don't do it before a year unless there is any other clinical indication of an infection or a pneumothorax or pneumomediastinum or any such things. If the progression of symptoms cannot be explained solely on a pulmonary workup, you can get an echo done. You might also require vitamin B12s, anemia levels, or any other things which may be clinically indicated to check. Now, if you do have a case of a fibrosing ILD who has progressed in the first 6 months or 1 year of follow-up, in spite or despite of giving an adequate treatment, how would you manage the patient? Again, here the patient is the center of the treatment. So you need to inform the patient about the disease. Patients who even uneducated would understand with the help of media. You can explain the patient what the patient is suffering from, what kind of symptoms we are looking at, what kind of projected lifespan we are looking at. And these patients need a lot of emotional support. Imagine a patient within diagnosis of ILD within 2 years going on oxygen therapy. So emotional support is necessary. Here, you might need help of a radiologist or a pathologist if you have done a biopsy. You need to consider pharmacological therapies. You need to manage comorbidities. Pulmonary rehab plays a very important role. Symptom relief. Sometimes we focus so much on giving antifibrotics and immunosuppressants, you forget the simple cough and the breathlessness that the patient has. Supplemental oxygen if needed based on 6-minute walk test or hypoxia which is present, and evaluation for a lung transplant. So as I said, patient should be given adequate information. Oxygen criteria remains the same as with any other ILDs. If oxygen do start, it should be on for at least 18 to 20 hours or 16 to 18 hours a day. I've seen many patients just taking oxygen for 2 hours in a day or only when they exert. These things may not be the best approach in such patients. If there has been worsening of the health status, such as decline in physical functioning, you should consider starting oxygen therapy fast. And since these patients progress, we've had, I'm sure everybody on the panel also had cases where patients have progressed within 2 years, and we've seen patients' lung go from mild disease to severe disease within 2 years. In such patients, you need to have an advanced planning. You need to discuss with the patient what are we expecting. Imagine a patient who was mobile and now has come on oxygen and probably has restricted mobility. So these things need to be discussed with the patient. End of life care, if you see a patient deteriorating, should be there. Referral for lung transplant is like with any other ILD, and that should be considered, and if you have the facility in your area. Now, this is the most favorite part of everybody, pharmacotherapy. You have a patient in front of you, you want to give some medicines. So let's discuss that. If you have a case of CTD ILD or an inflammatory ILD, systemic immunomodulatory therapy should be given. Usually it is started with corticosteroids, and then you add a steroid sparing agent like mycophenolate or azathioprine, depending on the etiology, maybe methotrexate, cyclophosphamide, rituximab can be given. Though in ILDs or inflammatory ILDs, how much they play a role is not clearly defined. Immunomodulatory therapy remains the standard of care for CTD ILDs, idiopathic NSIPs, HPs, and in these patients, this should be the first line. If it is an undefined inflammatory ILD, we don't know, but if it's inflammation, you will try. But if you have a CTD or related ILD or an HP, probably these patients will respond to immunomodulatory therapy. So these are the patients where immunomodulatory therapy should be started. Obviously, you need to take risk of infections in mind. Would you add immunosuppressive other than corticosteroids with corticosteroids? So there has been an incremental benefit of adding other drugs to a background of corticosteroids in certain types of non-IPF ILDs, that is CTD and fibrotic HPs. But here, case-to-case based approach has to be taken for the effectiveness. How much immunosuppression are you achieving? Are you putting the patient at risk for infections? So if you're having a baseline steroid treatment going on, then you need to decide whether you want to add a mycophenolate or azathioprine to such patients on case-to-case basis. Where does antifibrotic come? And currently, the antifibrotic license for IPF, a form of fibrosing ILD, are nintedanib and pirfenidone. As far as PPF is concerned, nintedanib is the drug of choice which is currently there, or the one which has been approved. So it's a nintedanib is a tyrosine kinase inhibitor. We all know that pirfenidone is thought to regulate the activity of TGF beta. Now, here, when to add antifibrotic or whether to give antifibrotic or not. So, there has been some data about it. So, if you have an inflammatory type of ILD, you will start with an immunomodulatory drug. If you have patient has come to you with a fibrotic type of ILD, which is non-IPF, here is the data about those patients. So in the Indu trial, FVC decline was reduced by 57% when you're giving nintedanib. And here the background immunosuppression was not allowed except for biologics. So if you have a treatment naive patient with fibrosing ILD, nintedanib could be the one which can be started. If you have patients of ILD with or undifferentiated or SSC ILD, pirfenidone has been used in combination with mycophenolate that not only could benefit the patient but also has an acceptable safety profile because both are going to be metabolized by the liver. There, sometimes you might feel whether we should give this can be given together. In the census trial, treatment of nintedanib over 52 weeks also resulted in reduced decline in the annual adjusted mean FVC as compared to placebo. And here also half the patients were receiving mycophenolate. So if you already have a patient who is on immunosuppression, adding an antifibrotic again has to be done on case to case basis, monitoring the side effect profile and how much will it benefit the patient depending on the FVC decline or the serial CT scan should be discussed with the patient. So apart from IPF, the systemic sclerosis, ILD, and possibly RA-UIP pattern, antifibrotic medication should not be a first-line therapy if you have any other form of ILDs. In PPF, there is growing evidence that antifibrotic reduces lung functional decline regardless of the background immunosuppressive therapy. If the CTD-ILD patient has been on immunosuppression and now has converted to fibrotic ILD, which is progressive, you may add antifibrotic therapy to them. You need to monitor for adverse events when you're giving a combination therapy. So can they be given together upfront or it should be given sequentially? If I'm going to add antifibrotic therapy, the logic states if this CTD ILD may progress to fibrotic stage, why not give an antifibrotic upfront? So there is lack of evidence to support use of combination therapy with antifibrotics and immunosuppressants at the initial diagnosis. Sequential addition is advisable with an observation period of 3 to 6 months. That's why I said 0.5 years or 6 months to determine the decline in FEV1 if there is any. Addition or intensification of immunosuppression may be indicated in some CTD-ILD patients before you think of adding antifibrotics. And in some patients, immunosuppressants may be discontinued. If you see it's all fibrotic, there is no inflammation which is seen, or when the patient is not tolerating the combination, maybe the antifibrotic can be continued alone. So tolerance of giving together in all the three major trials, there was no difference in the adverse events in the group of people who received antifibrotic and immunosuppressants together. So currently there is no evidence of a higher risk of hepatotoxicity, but nonetheless take one patient at a time, monitor liver functions frequently, and also look for any infectious complications. Don't forget, these patients also have symptoms of breathlessness and cough, where addition of therapies for just reducing the sensation of breathlessness or maybe the NIV or BiPAP therapy might help. Maintaining physical exercise capacity to pulmonary rehab programs. I think all pulmonologists should have tie up with a pulmonary rehab program at their own place or a nearby place. These patients do benefit a lot. Long-term oxygen therapy is needed if there's resting hypoxia or a 6-minute walk test showing a desaturation. And these things should be considered as routine. Vaccinations for flu and pneumococcal should be given to all these patients who are coming to you with lung fibrosis. And last thing we forget is quality of life. If a patient has associated disorders of gastroesophageal reflux obstructive sleep apnea, pulmonary hypertension, if a patient is a smoker or a non-smoker, malignancy, cardiovascular diseases. Don't forget those diseases. These can affect your symptomatology and the overall outcome of a patient. So, in short, did I confuse you or did I convince you okay, what to do in a case of pulmonary fibrosis, which is progressive? Maybe there is no clear-cut answer. As I've been telling you, all the studies have also suggested, all the guidelines have suggested to take it on a case-to-case basis. So that is where I end my talk, and maybe in the panel discussion, we can come to point-by-point discussions. Thank you.
I think that was an excellent talk, Dr. Mehul. It was very comprehensive yet very crisp, and I think you were spot on the take-home messages. Whether it be diagnosis or how to manage the complications, how are those symptoms very important, and not ignore that, because ultimately what matters is not just survival but the quality of that survival. So I would like to take a pause and introduce the panelists for tonight, and we'll open for panel discussion. So we have a very talented and an interesting panel today. So I would like to introduce my first panelist, Dr. Sunil Kumar. So he doesn't need any introduction. He's the professor and HOD at the Department of Pulmonology, Andhra Medical College, Visakhapatnam. He's also the superintendent at the hospital. He's been the former senior consultant pulmonologist at Apollo Hospitals, Vizag, and also at NIMS, Hyderabad. He is in fact credited with conducting one of the first or one of the initial live thoracoscopy and EBUS workshops in 2015 at Visakhapatnam with Dr. Munawar from UK and Dr. Jayachandra sir from Hyderabad. And of course, he's had multiple scientific papers. He's specifically interested in intervention pulmonology, sleep, lung cancer, and thoracoscopy. And next panelist for today is Dr. Indu Bubna. She is from Mumbai. She is a consultant pulmonologist and the founder of Lung Care Clinic in Mumbai suburbs. She is attached to Criticare Asia Multi-Specialty Hospital. She's an ex-consultant at Bhatia Hospital, Mumbai. She is specifically interested in difficult-to-treat asthma, advanced lung disease, including ILD, COPD, lung cancers. She's also successfully completed Quantile's GCP course for participating trials and researches, and she's been a sub-investigator and principal investigator in a lot of studies. She brings energy to this panel, as you all will see eventually. Our third panelist for tonight is Dr. Shikha. So Dr. Shikha Jindal Gupta, she's an MD who's done a fellowship in sleep medicine from Safdarjung Hospital. She is also an EDRM and she's a senior consultant at Neo Super Specialty Hospitals, Noida. She's specifically interested in obstructive airway diseases and intervention pulmonology, sleep medicine, tobacco cessation, and critical care medicine. She is a member of SAAPS Social Organization and has worked for a lot of social community causes. She's been a gold medalist in medicine 2004 and has presented papers in various national and international conferences, and has been part of numerous research trials and has many publications as well. Finally, our panelist, Dr. Aishwarya Rajkumar, she's the clinical lead transplant pulmonologist at Dr. Rela's Hospital in Chennai. She's an experienced pulmonologist and interventionist. She is specialized in asthma, COPD, ILD, and sleep. She's done her clinical fellowship in lung transplant from Vienna Lung Transplant Program, also from Toronto Lung Transplant Program. She's a Royal College diplomate in lung transplant, and she's currently working at Dr. Rela's Institute. She's received the prestigious Times Power Woman Award of Tamil Nadu 2021 for her work during COVID, and the Best Woman Alumni over the past 20 years from SRM University. So with that, I welcome all my panelists, and I think we can start.
May I? Somebody has to introduce you, buddy. I mean, Dr. Samir, who has been is the captain of the ship today. Let me take the opportunity to introduce him. Dr. Samir Bansal, we all know, is a senior consultant at Pulmonary Critical Care Interventional Pulmonology at Apollo Hospital, Bangalore. He is a thorough gentleman. He also is the senior consultant and clinical head at Vayu Chest and Sleep Specialty Clinics. He's an associate professor at Apollo Health, has more than 45 publications, book chapters, and his areas of interest include severe asthma, ILDs, PPFs, hemoptysis, TB, and peripheral pulmonary nodules. Go ahead, Sunil.
Thank you, Dr. Mehul, for that kind introduction. So I think with that, we'll just start off the panel discussion. The format of the panel discussion, most of it, yes, has been covered by Mehul's talk, but still we'll take up a few questions, and go in depth into certain intricacies, and also that everyone is aware, okay, what are the latest guidelines and when to use certain things, when not to use. So, Dr. Sunil, if I may ask the first question to you, I know Dr. Mehul put it very crisply, but could you please recap that what are the key diagnostic criteria for progressive pulmonary fibrosis and how do they differ from other interstitial lung diseases? Could you shed some light on this, please?
Good evening, all. Thank you very much for your nice introduction of myself from the Dr. Samir and Dr. Mehul. Basically, first of all, let me profusely thank ICS, the president of ICS, J.K. Samaria, the Raja, the secretary of ICS, and both are very well known all over the world. I mean, India, in the pulmonary faculty in the last 20 years, maybe from the time I studied the post-graduation, of course. And now the Amita Nani Madam, the chair of ICS, for giving me this opportunity and also for wonderfully conducting this ICS webinar series. And coming to this topic of today, progressive pulmonary fibrosis, no doubt it's a really wonderful topic and a need of the hour also, because there are so many doubts in the youngsters as well as upcoming pulmonologist management of this thing. And I also thank our co-panelists to today's Dr. Shikha, Dr. Indu, Aishwarya, and myself also along with that. So let us come to your question first of all. Before that, I profusely thank and congratulate Mehul for elaboratingly describing about PPF in a very nice manner right from the etiology. And he touched everything, including the prone position and end inspiratory CHR, as well as rehabilitation also very nicely. That's a wonderful description. And coming to this question, what you are asking me around today, this basically PPF is a type of ILD, which is worsening of symptoms basically. That's what the entire thing is. So coming to definition of that is a patient with ILD of known or unknown etiology other than IPF, which are having radiological evidence of pulmonary fibrosis. But IPF coming to criteria as per the consensus statement from the ATS as well as the ERS and JRS ALT. The basic criteria are the three, and two out of the three should be there. So outline of this criteria is only symptomatic worsening. Second thing is physiological worsening. Third is radiological worsening. So first of all, first come to the first criteria like worsening of respiratory symptoms during the last 6 months or 1 year, and physiological evidence of disease progression, as already Mehul has told, absolute decrease and decline of FVC more than 5% predicted within the 1 year of follow-up. That is very important. Along with absolute decline of DLCO more than 10% of the predicted within 1 year of the follow-up. These two factors should be there along with the radiological. The radiological features, there are so many like, first of all, very important is in one or more of the following, what I'm going to tell, the criteria of radiological should be there, like increased extent of the bronchiectasis, the new GGOs appearing on the background of bronchiectasis. There's a new appearance of fine reticulation, as well as increased coarseness of the reticulation also should be there. And of course, increase the presence of the honeycombing, as well as the increase volume loss, that should be there. Any of the two criteria should be there to say it is a progressive pulmonary fibrosis, and that is in short. There are so many definitions and their interpretation, but this is very standardized and a consensus committee recommendations. That's it. Thank you.
Thank you for that, sir. So I think that does it. So ultimately, whenever possible, just look at the objective, the subjective, and the radiological criteria. Subjective being whether the patient is more symptomatic or not. Of course, as Dr. Mehul pointed out earlier, You have to rule out any other cause which may be causing a subjective worsening for the patient. Only then you consider that this could be because of the ILD. Apart from that, a spirometry criteria, a worsening in your FVC or your DLCO, and finally your radiological criteria. Any two of these three is what is required. Now, what should we note over here is that we are talking about PPF, progressive pulmonary fibrosis. So we are not, how do we distinguish from other ILDs is all the other ILDs can actually progress to fibrosis, and that is when we apply this criteria. So it's not that you see first and you label something as PPF at the first instance. It's basically a comparison in patients' day-to-day status, or maybe quarterly status or 6-monthly status. That is how you label somebody as progressive pulmonary fibrosis. So with that, Dr. Indu, in your practice, now why I ask in your practice, yes, because there has been data in across various parts of the world. In your practice, how many of your non-IPF patients, they progress to a progressive fibrosing type of ILD, and what do the studies suggest? You're on, could you unmute yourself, please?
Yeah. So thanks, Samir. I hope I add up to the energy which you all have already started with a lot of excitement, and there are a lot of questions around already. So see, in my practice, Samir, what I've seen is the number of the ILDs, the common ILDs which progress to the progressive phenotype are basically autoimmune ILDs, which are usually the rheumatoid arthritis, the systemic sclerosis, myositis ILDs. Then you have the HP, chronic fibrotic HP, which progresses very fast. And then you have the idiopathic NSIP and sarcoidosis. Okay, so if I have to put a number, then it would be around 25 to 30% which progresses into the progressive phenotype. And based on the studies which are saying, actually these studies were done in the autoimmune diseases only. So one study was done including the rheumatoid arthritis ILD. The second was about the systemic sclerosis ILD, and the third was with the mixed connective tissue ILD. So all these three studies, based on these, it was found that around 18 to 32% of the ILDs only progress to progressive pulmonary fibrosis type of the ILD, despite the initial appropriate management, and within 60 to 80 months it progresses. So that's about what the studies say.
Right. No, I think that's a fair estimate. In fact, most of the studies, as you pointed out, these were restricted to your connective tissue disease or autoimmune or IPAPs, basically. However, there have been data, not larger studies like this, which do suggest that even other conditions such as hypersensitivity pneumonitis, there is a high risk of progression in these conditions also. In fact, when we were also looking at our data after this joint consensus statement, we could find that roughly about 23 to 28% of our patients usually progressed. However, what the guidelines suggest, 60 to 80 months, what we saw in our cohort was over a period of 3 years, they started progressing.
And it progresses very quickly, the HP varieties. Yeah, that's what I've seen. In fact, within 1 year, I've seen that it progresses very fast.
Yes. So that's what, so despite whatever treatment you give, the best standard of care, of course, multiple times, it's not up to us to ensure, it is up to you, but you cannot really ensure 100% compliance with each and everything, rehabilitation and all. But despite the standard of care, whatever you do, approximately, I think about 31% of patients do progress.
I mean, I also feel the HP variety progresses fast because there is a continuous antigen exposure.
Absolutely. In fact, in one of the, as per the ILD India registry, also the most common variety being hypersensitivity pneumonitis, and more cases are being diagnosed with HP. Of course, we do not have concrete data on that, but in a recent talk, I think Dr. Ganesh Raghu sir was there, and he also mentioned, there's just background pollution and so many other exposures are there, which constantly keeps causing this inflammation and then fibrosis cycle, and that is something which can lead to this progression quite rapidly. Right. So, Dr. Shikha, so I just have a clinical scenario for you. So you have a patient who has symptomatic improvement. However, when you repeat a CT, say after 9 months, 1 year, whenever you routinely do it, and you see that the CT scan is also perfectly fine, but the PFT at the end of 9 months is showing a decline in FVC by about 10%. Now, would you consider this patient as having progressive fibrosis, or would you rather repeat a spirometry, and how soon would you want to do that?
Yeah, hello. I thanks ICS for making me a panel for this wonderful discussion. So yes, Dr. Sameer, so a patient who is clinically stable, radiologically there is no deterioration, but FEC has declined more than or equal to 10% in 9 months. So definitely, I would actually, the PFT itself, we should not just go with the PFT, because sometimes the reproducible criteria is not met. And it's not just the FEC which is depicting the pulmonary, it is also depicting your extrapulmonary, whether it's a steroid-induced myopathies, whether it's because of the cardiac reasons or any other reason or any kind of reason. So just seeing the FEC, I will definitely not label that as PPF. I would definitely follow up the patients with repeat spirometry. But yes, this criteria has been taken in one of the trials. That's the inbuilt trial, where this alone, this FEC criteria of decline of more than 10% has been taken as a standalone trial, standalone criteria for categorizing it as a PPF. But practically speaking, I will not. As also we have also said that 2 out of 3 criteria is important to label it as a PPF.
No, I agree. And I think it was quite spot on, because just based on the spirometry, we never judge, especially when your patient is symptomatically doing better and there is no progression. So back to our criteria, 2 out of the 3 criteria are important when you label as progressive fibrosis. Now, herein I'll also like to make a point, because always look at where the spirometry is done. Is it done at the same place or not? Because many times, the operator or the technician who's making you do the spirometry, the level of motivation may be quite different. And second thing, please look at the equation which is used for spirometry. Now, off late, we've been seeing so much variability, a person going and, based on different equations, because some equation may give percentage predicted at 90%, for the same person, same patient, another equation may give it as 70%. Now, it all depends on that absolute value. So please look at those equations properly, because we have seen, certain rheumatologists and certain other physicians making certain decisions based on these various spirometric values. So please, number one, make sure you have at least 2 out of 3 criteria. Second thing is, look at that spirometry. And third thing is, if at all doubtful, please repeat that spirometry. So Dr. Aishwarya, we looked at the clinical criteria. We've spoken about the spirometry. Now, CT scan. Now, in your opinion, what role does a high resolution CT scan play in diagnosing and monitoring PPF? And what are the specific features which indicate progression?
First of all, thanks to ICS for giving me this opportunity to be one of the panelists in this discussion. And thanks to Dr. Sameer for the kind introduction. And as Dr. Mehul mentioned in his talk, he had mentioned about the importance of high-resolution CT. So especially in progressive pulmonary fibrosis, it definitely adds up in terms of prognosticating the disease. So it helps to HRCT plays a major role in terms of prognosis and in terms of going through disease progression, and in terms of looking into how the medical management is working on this patient. And during every exacerbation, it also helps us to identify if there's any other new changes that's happening. So a CT definitely plays a major role in terms of diagnosis of progressive pulmonary fibrosis. And also radiologically, there is a score that is a quantitative lung fibrosis score, which is a collective score of a quantitative ground glass opacity, quantitative reticular opacities, and quantitative honeycombing. All put together, we have a quantitative lung fibrosis score. So this score definitely helps in prognosticating in conjunction with PFTs, as well as the clinical prognosis. It helps to understand how the disease is progressing in a patient.
So now, Say you see a patient, the patient is presenting with some worsening. You see PFT that is also worsening, and for some reason you cannot really do a CT scan. I mean, it could be anything. Would you still want to wait for that CT scan to label this person as PPF before maybe starting on some antifibrotic therapy or change in your management, just to confirm that yes, there is indeed some progression? Or just otherwise also, can you take this decision?
Definitely, even otherwise, we can take this decision. I mean, if a patient is progressing in terms of drop in FVC, DLCO, clinical symptoms, and that frequent exacerbation, hospitalization, all this is also enough. If you're not able to make the patient do HRCT, if you're not able to make the patient lie flat, then definitely we can consider this patient as worsening prognosis and increase our medical management.
Right, absolutely. So again, just recapping the whole thing. So you do not really need a CT scan always, especially if you've been seeing a serial drop in your forced vital capacities, your DLCO, or maybe symptomatic worsening. Then you can definitely label this patient as a progressive fibrosing variety and appropriately take those management decisions. Now, whether it is exacerbation or actually a progression in fibrosis, these are certain situations where a CT scan may definitely help to just see whether, increase in immunomodulators or an antifibrotics. But in general, labeling, you would require a serial PFT, if not a CT scan.
Yeah.
Dr. Mehul, I think you've covered a lot in your talk and almost everything. But still, I would just want to ask one question to you. In your opinion, and according to the studies, are there certain factors that are associated with poor prognosis in patients with progressive pulmonary fibrosis?
Yes. So if, like Dr. Indu was mentioning, if you have an HP variety, so first of all, at what FVC or what lung functions has the patient presented to you? If it is already less than 65 to 70%, if the lung fibrosis score is pretty high, if you have a variety of ILD which is secondary to hypersensitive pneumonitis, and specifically in cities like Mumbai, Delhi, maybe Bangalore, continuous exposure to the antigen which is possibly there, these would be a kind of patients who probably will fare worse. If you have associated pulmonary hypertension, if there's a systemic sclerosis, ILD with pulmonary hypertension, if patient has associated other disorders like OSAs, malignancy is already there. If you find a UIP pattern initially, a patient who is smoking, any other risk factor for a lung disease, these patients would fare worse. So if you see any of these criteria which are present in your patient, then your, the criteria to start antifibrotics or the difference between the two follow-ups can be less.
Right. No, I think that's a very important point because, when any of these factors are there, so rather than, the standard practice that, okay, I would rather wait for 3 months or 4 months to do that PFT or to do that clinical follow-up, you can always take a decision that, yes, I need to follow this patient up more closely, more frequently, and then take those management decisions accordingly. So it is important that how these different things, the pattern, UIP patterns, or, what is your background disease, such as a rheumatoid arthritis related ILD, or maybe a hypersensitive pneumonitis or pulmonary hypertension, when any of these are present, please monitor your patients more closely because they are likely to worsen or likely to progress faster than your other ILD patients. Dr. Sunil, now I know we have already discussed about this to some extent, but can you shed some light on the prognosis and how it varies across various ILD phenotypes who have progressive fibrosis?
Yeah. Yes, I mean, actually, Mehul already told that there's a difference in different types of prognosis factors and associated prognostic factors like pulmonary hypertension and all. Coming to your question that there are so many number of subtypes of ILD, as you know, from our post-graduation days, and you can say innumerable also. But as per this Mehul slide of the algorithm, there are almost 20 to 30 subtypes usually now. So each subtype is having different risk of progression as well as prognosis. So before treating anything, thus we should know the initial diagnosis of the subtype is very, very important. Why? Because patients with PPF group demonstrated a significantly poorer survival than those with the non-PPF group. Previous study shows both groups are having same prognosis, but recently there was a study by one at all at 5-year survival rate, where PFILD is having a 5-year survival rate of 64%, whereas non-IPF ILD was having 89% of 5-year survival rate. So that's the prognosis also depends on the type of subtype of the PPF. Basically, there are so many classifications, but unclassifiable ILD definitely has a poor prognosis than those with the identifiable ILD subtype. So basically, this has to be appraised by all the participants, because there are so many unclassifiable ILD which are having PPF going into poor prognosis than other identifiable subtype. Suppose if you take CT-ILD, especially with idiopathic inflammatory myositis, is having a significantly slower progression when compared with other like anti-melanoma differentiated associated gene 5 type of rapid progression of the PPF is there. But the thing is that what we should apprise is that if the ILD progress is there despite of optimal management with immunosuppressive therapy or whatever, the risk of further progression does not usually appear to be influenced by the subtype of ILD. That's the thing actually from the listing.
Right. No, I think you said a very important point out there, Dr. Sunil sir. Number one is that yes, if you are not able to classify a specific pattern on the CT scans, and this has been found across various studies, unclassifiable pattern usually has a poorer prognosis and chances of progression are much higher as
Right.
compared to any identifiable pattern on the CT
Yes,
scan.
yes.
And the second thing, even when you have a identifiable pattern, but there is a family history, a familial ILD, that is also something which chances of progression are higher. And if you have a UIP pattern of fibrosis, be it hypersensitivity pneumonitis or RAILD or systemic sclerosis, and these are certain things which you should follow up very frequently or more frequently and see for that progression, and maybe start your therapy, antifibrotics or whatever, maybe early as compared to other kinds of ILDs. So now that we have started this discussion on antifibrotics and management, so Dr. Indu, what is the current evidence supporting the use of antifibrotics in progressive pulmonary fibrosis, and how does it compare to IPF?
Sure. So basically, Sameer, it's like the consensus statement usually recommends that first you should have an accurate diagnosis of the fibrotic ILD. Moving from there, you should look for the risk factors of the progression of the disease. Once you see any radiological, clinical, or the physiological deterioration, and you see the progress of the ILD, and if the standard regimen, which is steroids and immunosuppressants, are failing and there is a progression, then you add antifibrotic. So committee usually recommends against the initiation of the antifibrotics upfront. So other than the rheumatoid arthritis, systemic sclerosis, and one more, which is mixed connective tissue disease, we don't recommend upfront antifibrotics. And regarding, we have got two antifibrotics basically. One is pirfenidone. So the committee recommends that further research is required into the efficacy, effectiveness, and the safety of this drug in the non-IPF progressive phenotype, and in both the groups, basically in the general population group as well as in the select non-IPF ILDs also. So there were two studies which were done. One was basically the relief trial which was done. It had only some around 100 to 200 patients. So the study got terminated early because of the slow recruitment. So regarding PERF, I would say it is still not approved in the PPF ILDs. And regarding the nintedanib, the committee has approved for the treatment of the PF ILDs only when the standard treatment is failing. So everybody needs to understand, whoever has logged in, that antifibrotic should only be included after your standard regimen is failed, And there was this one trial which was done, inbuilt trial, which recruited the PF-ILD patients, chronic fibrotic ILD patients, and one arm received placebo, the other received NINT. And what they have seen is there is a reduction in the annual decline of the FVC. There was a reduction in the acute exacerbation and also in the disease progression. So yes, NINT is approved for the treatment of the PF-ILDs.
Right. Thank you so much for that. It's important to understand this, that yes, there is a lot of evidence in PF-ILDs, but most of the evidence is skewed towards nintedanib. When it comes to pirfenidone, the evidence, even though it is there, it's weak currently, and therefore it is not really recommended per se as an upfront or maybe as first-line antifibrotic therapy in these category of patients.
Yeah. Also, I would like to add regarding the nintedanib, they have also further recommended further research into the select IPF-ILD patients for the safety and in the select group of the population, because what they have seen is in the chronic fibrotic HPs and unclassified ILDs, they have not seen that much of reduction in the annual decline in the FVC. So further research is still required.
Right. I think this is also something that all of us, experience. I'm pretty sure, because we do on a routine basis that you throw medications after medication, but still you do not see any response. Now that may be, an indication that, okay, things are not working, and possibly certain other things such as rehabilitation or maybe lung transplant may be required. So I think very true, and something which is required as well. Mm-hmm. So Dr. Shikha, now you have a patient who another clinical scenario. So you have a patient who you have labeled as idiopathic pulmonary fibrosis with maybe a probable UIP pattern, but with high confidence, versus a person who you have been seeing, or patient you have been seeing, and now you have labeled PPF. What criteria do you follow before starting these patients, or rather, how does the criteria differ when you start these two patients on antifibrotic therapy? When do you start, and what do you see in these patients?
So yes, so patients IPF, we know that IPF, it's a clear diagnostic pathway. We know that antifibrotics are the drug of choice for them, and we can straightway start antifibrotic to IPF patients. So when coming to the non-IPF ILD who have been labeled as PPF, so we know that these patients can be started on antifibrotics once they have failed the standard management. So already the patients are on immunomodulators, immunosuppressants, steroids, but once they have failed that standard management, you can consider antifibrotic in such patients. And this is what Dr. Indu has mentioned all this, that we have seen a role of antifibrotics in inbuilt trials, the census trials, that how the improvement in FVC has been seen in such patients. So yes, so a patient who's been failing on the standard treatments, you can consider antifibrotic. They are not the first choice of the drugs in case of non-fibrotic IPF, but in IPF, yes, these are the first choice.
And I believe the choice of agent also, because you have a wide, not a very wide list. Of course, you have two different agents for IPF, whereas for as we already discussed, but this majorly nintedanib currently. And I think that comes from the fact that most of these progressive pulmonary fibrosis studies have been done on patients with autoimmune ILDs, wherein the trials have already been done for nintedanib. So that also maybe makes a case for using this drug. So, Dr. Aishwarya, now this is a very interesting question which I wanted to have your opinion on. Now we know that as we discussed earlier, Dr. Indu also mentioned that roughly 30-35% of patients come what may, despite standard of care, despite whatever best care, they do progress. They have some progression. So why not start upfront antifibrotic therapy in all? Would you consider doing it that eventually, yes, some of them are going to progress? I don't know whether this patient will progress or not. So should I just do it? And we have been seeing, so many patients get referred to us who, as soon as the radiologist labels as ILD, one drug which is out there is either pirfenidone or nintedanib. What are your views on that?
Okay, I mean, now that three of them have spoken about this, as Dr. Indu said, like starting up front for a non-IPF is not really indicated. But I mean, considering the question, ideally it is only the nintedanib that works on these patients, and two, the drug also works ideally for patients with mild to moderate impairment in lung function. So, if the patient has already gone into a state of progressive pulmonary fibrosis, wherein there is extreme destruction of lung functions, maybe the nintedanib doesn't really work as well. And also, and all these trials, that's as Dr. Mehul also mentioned in his presentations, the inbuild and census trials and all of that says there is definitely a reduction in the progression by 57% in terms of FVC. So if that's the case, and if that's almost 1 year into the therapy, the patient's progressing a drop in FVC is reduced, I would definitely consider starting along with the mainstream medications of, like, say, steroids, immunomodulators. Probably we could start these patients, because I also do that. I mean, when you consider a patient of an ILD going in for a lung transplant, wherein you know that this patient is a candidate, but they really need some time. They're looking for buying time. The patient is not really ready. There's a lot of, as said, there's a lot of emotional factors. They're still not trying to understand the disease. But when you know that this disease is going to progress in a couple of years, I think along with the immunomodulators and steroids, MMF, it is okay to, I would definitely start the patient on antifibrotics if the patient is tolerating. Again, these medications have liver implications. Toleration can be hard, along with especially MMF. So if we can, I think it's okay to give a trial. I don't know what the other panelists think about it.
Yeah. No, so I think you brought about a few interesting points. Number one, yes, we always debate that, okay, if you have a fibrotic ILD, say maybe IPF, you upfront start an antifibrotic, but when it is an inflammatory ILD or a non-fibrotic ILD, non-IPF ILD, you wait, you start with anti-inflammatory therapy. However, if a patient presents to you at an advanced stage, especially, autoimmune ILDs, when you can see florid fibrosis, the patient is not really doing well clinically, then it all depends on your clinical judgment as well. That, okay, there is already so much fibrosis, so the patient has been progressing. These are certain situations when you can add upfront antifibrotics. However, for each and every ILD that gets labeled as ILD at the first presentation, we should not really do that. If there is florid fibrosis, if the fibrosis score is high on your CT scan, and all these various scoring parameters also say, okay, the reticulations are more, or maybe there's significant amount of traction bronchiectasis or honeycombing. And these are category of patients wherein, yes, it may be justified to use upfront antifibrotics to prevent further decline in these patients. I think we can hear the views from other panelists on this also. I think Dr. Indu, you want to comment on this? Could you unmute yourself, please?
Yeah. So basically, Dr. Aishwarya actually mentioned an interesting point about if the patient is referred for a lung transplant, then the addition of the antifibrotic would probably buy time, as it reduces there is a reduction in the annual decline of the FVC. So obviously the patient symptomatically also improves, in a way, as the disease progression slows down. So I think that is one interesting point she's brought. And then you have mentioned that florid fibrosis. So I think, yeah, in some cases, see, the decision to basically start switch or, to kind of stop the antifibrotic, it is individualized. It depends upon the patient's, disease stage. It depends upon the comorbidities. And it also depends on the other things. So I think we cannot just put a hard and fast rule, but broadly, we can say it should not be started upfront, as you said. You see a ILD patient and you start antifibrotic. No. So
absolutely. I totally agree. So yes, decisions do change case to case basis. You have to take the family into account, into the discussion regarding potential side effects and everything, and then take all these decisions.
Also, when inappropriate treatment actually leads to more of adverse events, because if you see the immunosuppressants and then if you see antifibrotics, they both affect the liver enzymes. So I feel you are adding to the adverse events by starting the inappropriate treatment. So first, I think you should first diagnose the fibrotic ILD accurately and then think about addition of the.
No, absolutely. I totally endorse that view because you're just adding on to the pill burden and the side effects also. So based on this, only my next question, building on this whole thing, Dr. Mehul, so the patient who an inflammatory non-IPF ILD, you've given the proper standard of care. The patient seems to be progressing. The fibrosis seems to be progressing, and you are considering antifibrotic therapy. Now, would you consider stopping the immunomodulators while starting the antifibrotics, or would you just continue it? And how safe is the combination? I mean, you have covered certain aspects in your talk, but still, if you could shed some more light on this.
The short answer is no, I won't not stop the immunosuppression. First of all, I would not have the heart to stop the immunosuppression. Patient was an inflammatory ILD for which immunosuppression was given and now has had an additional new finding of progressive fibrosis. So I would like to continue both if the patient is tolerating it. If there's a background CTD, I may not be anyways be able to stop an immunosuppression because it may be required for a CTD related reason. So if I'm giving a steroid with any of the antifibrotics, generally that would be safe if you're asking me that. If I'm giving a steroid sparing agent or if the patient is on steroids, a low dose with mycophenolate, many combinations that we see, and I'm adding an antifibrotic, I may step down one immunomodulator, but I will need to monitor the patient's liver functions, see the immunosuppression that I'm achieving, pill burden, and the cost. I would not be stopping, short answer, but yes, case to case basis, if the patient is having some side effects, if the patient is already now, say, many times you might also face in Bangalore, patient has visited, an ILD patient goes from one doctor to another doctor to third doctor. Patient has had so many prescriptions now and now has a lot of side effects. You see all fibrosis in the lung, behaves like an IPF. Probably I may stop immunomodulatory treatment in that patient. But if overall, no, I would still continue it if possible.
Absolutely. I think the point to remember over here is because all these inflammatory ILDs, there is an ongoing insult. There is ongoing inflammation, which
Exactly.
then brings about your fibrosis. So, as much as possible, yes, try and avoid stopping these immunomodulatory drugs, especially in your inflammatory ILDs. But at the same time, as Dr. Mehul just rightly pointed out, it always has to be a case-to-case, decision. If your patient is tolerating it well, why not? You can continue everything. But if the patient is having frequent side effects or adverse effects, or making his or her quality of life poor just because of the pill burden, yes, you may take that individualized discussion or maybe drop down the dose if at all. So these are certain things which one has to consider rather than stopping it completely. So yeah.
Here is a point, dropping the dose of what? Immunomodulation or antifibrotic? Because here, if I'm giving nintedanib, patient is having some GI side effects. I go to, what I do, I'll tell you, what I probably might change the nintedanib to pirfenidone, though the data is very sparse of pirfenidone, probably because there are no major studies. But I feel if nintedanib is not tolerated, I need to give an antifibrotic, I might go to pirfenidone. So I don't know what others do. Do they still give pirfenidone in PPFs or no? But yes, reducing dose, sometimes you may need to reduce the dose of antifibrotic also or change the antifibrotic.
Yeah, no, I do agree. And because, it's a very gray area, there is not much guidelines on this. So I feel still it's, a very personal opinion based or a personal practice based paradigms that we still follow. But yes, initially when we are starting all these therapy, personally, now, of course, this I don't endorse on a wide view, is that we like to go slow. We like to see, say, one pill, see how the person is tolerating, then add on another. And similarly for MMF also, whenever we feel the need, we keep adding on a weekly basis, see how the person is tolerating. And once you reach that maximum dose and there are no side effects, we just continue it. And if at maximum dose patient is not tolerating, maybe we just step down by 500 milligrams or something like that. Again, no data on this. It's just a very personal opinion.
Yeah. Indu, you're on mute, please.
So, Mehul, you brought about a very interesting point when you talked about switching. I mean, if the patient doesn't tolerate NINT, you would add PERF, and PERF is not recommended. That's a very interesting point, which actually I didn't think of earlier. What I'm saying is, PERF study actually, which was done, it actually showed there was a decline in the annual FVC decline rate. The only thing, the study got terminated because of the slow recruitment. So I think PERF has got a role. It just we don't have enough research.
Absolutely.
So interesting point, Mehul. Great.
Yeah. So Sunil sir, few subtypes.
I also just want to comment one thing.
Yes.
So
Go ahead.
I have 3-4 patients who have not tolerated Nintina, and they are like very much tolerating Perfenidone, and they are doing great. So I too have switched patients among the antifibrotics, and I have seen the results.
Yes.
Oh, that's great.
So I think all of us have possibly such kind of patients who do not tolerate one but tolerate the other well.
Yeah.
So of course you cannot tell that no, there is no scientific benefit for this, or there is no evidence for this. So I would rather not put you on anything. So yes, I think case to case basis these things are seen by everyone.
And if I can add just one more point, like I've noticed with many patients who are on nintedanib, they have severe gastric reflexes on top of the dry cough that the patient has. The gastric reflex makes the cough worse. So I've switched patient from nintedanib to Perfenix in many cases because of this reason.
Right. So, Dr. Sunil, now certain subtypes of ILD, especially the myositis related, especially the MDFIs. Now, there's been so much literature on this that these patients progress really fast. So what do the guidelines recommend in these cases? And are these the cases wherein if you say do an extended myositis panel and you come up with this kind of a phenotype, would you want to start upfront antifibrotic therapy in these patients or not? Because what data suggests, what certain studies suggest, I don't think they have a very hard and fast number on this, but what they said, the progression is rather rapid in these patients. So your comments on this variety of ILD, sir?
Yes, Shamir, I do agree with Mehul and Indu madam and Aishwarya. There is a combination of treatments going on. Actually, the patient-to-patient variation is usually there. And no doubt nintedanib is going to have some kind of GI disturbance and all. So based on personal experience, keep it aside. Coming to the, studies where it is going to take. So upfront antifibrotic therapy, yes, we have to go for that. According to a study in China in the year 2023, Lee et al., where they have given 30 patients with rapid progressive ILD, both anti-MDF, AB positive as well as negative dermatomyositis type variety. They received around 1800 milligrams per day about perfenadine versus 27 retrospective cohort studies. In that studies, they showed a relatively lower mortality in the subgroup of those who was taken perfenadine. Again, in the literature, when we go into detail, so it is showing that subacute variety is going to respond better than the acute variety. So that is also very, very important when you do a combination of therapy as well as starting up perfenadine as an antifibrotic. This thing. So perfenadine may enhance prognosis for a subacute ILD related to EMIopathic as well as dermatositis ILD. That's my take on this perfenadine actually.
Absolutely, sir. I also agree. As we were discussing, okay, if your patient has significantly high fibrosis score, or you have a variety which is known by evidence that, okay, it can progress very fast. Now, these are variety of patients wherein you can start upfront antifibrotic therapy also. But mind you, do not do that in all patients, and try to go and evaluate the cause for ILDs, because if it's an inflammatory ILD, try with just and immunomodulators rather than upfront. But yes, if those patients show all these antibodies, MDF5 and others, which are known to progress rapidly, you can very well put these patients on upfront antifibrotics.
So, Sameer, I would just like to add about the autoimmune ILDs. We have seen we don't intensify the immunosuppressant dose, rather than probably adding
Absolutely.
antifibrotic, I would like to make a point that we should intensify and give the optimal dose that the patient tolerates and then think about adding an
I think,
antifibrotic.
very valid, because this is something which we also see often, that, your immunomodulator dose is not really up to the mark, or not really the maximum dose that you can give. And despite that, you want to put on antifibrotic. Of course, that is not the right practice. Make sure that the full standard of care is being given. Only then you consider.
Also, in fact, it is recommended that we can actually stop immunosuppressants if there is no beneficial effect that we are seeing, and then add an antifibrotic.
Yes.
So that's one point.
Absolutely.
Absolutely.
So I think, building up on the point that we were talking about, so Dr. Indu, when do you consider failure of antifibrotic therapy? And, at this point, would you consider switching to another antifibrotic? And finally, third question, all in one, is any role of dual antifibrotic therapy? Because there have been people, I have seen myself, okay, people coming to me with both nintedanib and pirfenidone together. So what do you think? What is your opinion? What do the studies say?
So this is a hot question. Thank you for forwarding it to me. So I like the question. I see, we can consider failure of the antifibrotic when we don't see any beneficial effect of one antifibrotic over 6 to 12 months. Then we can tell that, okay, patient has failed this antifibrotic, and we can switch to another antifibrotic. And switching can be considered in case of the disease progression, or it can be considered when the patient is not tolerating a particular antifibrotic. But there's no conclusive evidence that switching actually benefits in the case of the disease progression. This phenotype, whether this switching helps, studies are not very, very conclusive. And the decision, again, I would say, of switching the antifibrotic or to stop the antifibrotic should be individualized. It depends upon the patient's comorbidities, the drug toxicity, patient preference, a lot of other things. And the very burning question about dual antifibrotics. So there was this trial which is done in the IPF patients, which is In Journey trial 2019, which recruited IPF patients actually. One arm received NINT and the other arm received the combination therapy, which is NINT plus PERF. And this study was actually, they evaluated the safety and the tolerability of the combination therapy. And what this study found out was there is a good manageable profile in this combination therapy in line with the adverse events. So, but the further research is required in PF-ILDs basically. So there is no data about whether we can give dual antifibrotics in.
No, so, but say you've started your patient on nintedanib, and it's been 3 months, 6 months, and you still see a progressive decline. So when is that cutoff? When you decide, no, this is not working out, let me switch to it? Or do you really feel that no antifibrotics are going to work in this patient, so let me just, maybe do something else, say palliation, lung transplant? So what is your practice like?
Sure. So see, if I would wait for over 6 to 12 months at least, we'll do a serial PFT. After 1 year, we can do an HRCT and we can see whether the disease progression has happened or not. And if there's no disease progression, then I would like to switch to a different antifibrotic. And regarding what did you ask next?
And the whole thing was, the same, whatever you have answered. I think one of the logics behind putting both the antifibrotics together has been the different mechanisms of action. Because pirfenidone, nobody really knows. But, would you put your patient on dual antifibrotic therapy is my question.
So switching, I would, yes, because I want to try a different mechanism of action and see the treatment outcome. But dual antifibrotics, see, what I've seen is during the COVID period. So half dose of PERF was given, half dose of NINT was given, and both the antifibrotics were combined. So that was a different scenario altogether. But I have still not started dual antifibrotics for at least PF-ILDs. I don't know in future if I would like to explore that.
Right. No, I think it's just, so many medications with a lot of adverse events. The GI adverse events have been quite pathetic. In fact, I was mentioning that I have seen multiple patients being referred to us, or rather who come for a second opinion after they've tried multiple therapies and all. And we've seen the gastric side effects, GI side effects just being too many when you add these two things together.
Okay, about the dual antifibrotics. But single, I would say the nintedanib is tolerated very, very well. Besides the
Yes,
diet.
of course, I think it's patient to patient because some patients tolerate nintedanib better, some patients tolerate pirfenidone better. So, but in general, acceptability profile is pretty good with nintedanib.
Correct.
Yes.
Yeah.
Samir, have you ever used the dual antifibrotics?
No, personally not, and I don't really recommend also because the data, number one, is very, very scant, and as Dr. Indu pointed out, only in a subgroup of IPF patients, not in other PPF varieties. So at this point, I would definitely not recommend using it, and neither have I. What I done is those patients who've come to me, I've stopped both the therapies and put them for lung transplant.
But before going to lung transplant, I think we can just try a combination of these two as well as pirfenidone also or the nintedanib. So leaving entirely antifibrotics is how do you feel like?
In the sense that ultimately, I do get your question stopping. So it is just that, yes, when the patient's safety profile from a point of view of antifibrotics or, other medications has been so bad. So that is the time when I usually like to hold it off, get the patient because, if they're not eating and we see slowly progressively declining muscle mass in these patients, then they're not able to do active rehabilitation. And that is what really takes them down. So in these certain set of patients, okay, when we know we have listed these patients, they are about to get a transplant done. Nobody can guarantee, okay, you can get it in 2 months, 3 months, whatever. But initially we try to calm it down, and then if at all required, we add one, as I mentioned earlier, cautiously, just to make sure that okay, these patients are not having enough side effects to reduce their appetite and otherwise also.
Yeah, I think great point, Samir. You have mentioned that lung transplant should be actually the discussion should happen when you have started noticing the progression of the disease. Immediately, I think the discussion should start. And I have seen the acceptance of the lung transplant is also good when you start the discussions early. The only problem happens from the financial point of view, but otherwise the acceptance, I think people do want to go for it. So I think the discussion should start early.
No, absolutely. I think Dr. Aishwarya can shed more light on it. I mean, she's great at that, and I think she does a lot of these transplants. So my next question is to Dr. Shikha, alternatives. Let's move on from antifibrotics. So Dr. Shikha, your opinion regarding macrolides in management of PPF. There have been certain studies which do mention the role of macrolides. What is your take on it, and can you shed some light on this evidence, please?
So, as we all know that macrolides are antibiotics, and we have seen the role of macrolides, long-term role of macrolides in COPD in the form of immunomodulators as an anti-inflammatory. So we know that macrolides do act like an immunomodulators, anti-inflammatory, and helps to reduce the inflammation in the lungs. Apart from that, the studies have also shown that certain macrolides, especially the studies on azithromycin, have also shown that they act as an antifibrotic and slows the fibrosis process. And another interesting thing which I read about the macrolides, it's something which is very recent, is the microbiota modulation. That these macrolides, they modulates the lung microbiota, which these organisms, these microorganisms are responsible for development and progression of the lung fibrosis. So they modulates this lung microbiota somehow, and then they causes slower down the fibrosis process. So yes, the studies are showing certain promising role of macrolides, but I still feel that we really need more studies, more robust studies to actually label that they have role in PPF. But I feel that studies which have shown the role of macrolides, probably the patients who are not tolerating your immunosuppressants or steroids, or not able to, or they are failing on the treatments, which are whether it's the first line or the second lines or the antifibrotics, we can try the macrolides in such patients. But I think we need more studies regarding that.
So I think the latest evidence, there have been a lot of studies, as you rightly pointed out, both for azithromycin as well as clarithromycin. And they do say that these are immunomodulatory, yes, because they work on IL-6, IL-8 pathways. And one of the latest ones also showed that it works on NADPH oxidase pathway, which actually can reduce the progression of fibrosis. So there has been some promise, especially with respect to clarithromycin out here. Plus, as you rightly mentioned, because of their antibiotic activity, they modulate the microbiota in the lung also, which can further reduce your ongoing inflammation because of the aspirations and the infections, which can in turn reduce your fibrosis. But the whole question is, do you really need to put those when your immunomodulators are going on? How would that pill burden be there? And we know that the macrolides, they do interfere with your GI motility. So how are the patients going to tolerate that GI motility? So there are certain questions, and that is why it is still not really recommended as a part of guideline. But these are certain things that maybe as a desperate event, if the patient is just having infective exacerbations one after the other, in those cases, possibly we can try these out. I'm not sure whether anyone else in the panel has experience with the macrolides, especially in PPF cases or not. I think feel free to comment. Okay, so I'll take that as a no, not much experience with it right now. So yes, we had started discussing regarding lung transplant. So who better than Dr. Aishwarya? So at what stage, I think this was the point brought about by Dr. Indu, at what stage should these progressive fibrosis patients be referred for transplant evaluation or, referred for a transplant program? And what factors influence this decision?
Okay. First of all, before I answer this question, I'd like to share my experience. So working in the West, so what I realized was earlier you refer a patient for transplant, the outcome of transplant is good. So I'm still working on a study with Toronto General, which is a frailty study, wherein this was also presented in ISHLT Prague last year. So basically, in this study, we calculate the phenotypic frailty, cumulative frailty, pre-transplant, and if we come up with a frailty score. And if the frailty was a high pre-transplant, these patients, even if you transplant them during the post-transplant, during the early post-transplant phase, their frailty scores either try to stay stable, it doesn't really go down, or in fact the outcomes are worse. So I feel the Indian outcomes, so after working in Europe and West, I feel the Indian outcomes are really poor because the time at the point where the patient is referred to us, they're not at all on pulmonary rehabs, they're extremely frail, and that's why the Indian outcomes, even the immediate post-transplant outcomes, we're not able to produce more than 80%. So now I would like to highlight what is a ISHLT guideline. So this is the referral guidelines which is followed all over the world. So the ISHLT guideline, that is, first we identify the candidate as transplant candidate. So we follow up on these candidates. That is, any patient with a UIP or an SIP pattern, FVC of less than 80%, DLC of less than 40%, and any dyspnea or functional limitation, any requirement in oxygen, that is even on exertion, and failure to respond to any kind of medical therapy, which you're following up for almost a year. So these patients would be a candidate for transplant eventually. So you follow up on these patients. And when you actually list these patients for transplant is when this FEC falls less than 10% during the 6 months follow-up. And if there is a decline in DLC of less than 15% in 6 months follow-up, and when the SpO2 falls less than 88%, even on walking 250 meters, and then patient develops pulmonary hypertension, which is either identified by an echo or a right heart cath, and patient has recurrent exacerbations or hospitalization on pneumothorax. So these are time to list the patient. And given our Indian scenario with very limited, the donor availability in our country is lesser, and especially say if the patient has a blood group of O positive, or if the patient is a female with a short stature, and for such patients, I feel if the patient is not responding to medical therapy or any of these ISHLT guidelines, criteria that they fit into, I think it's highly recommended to prime the patient for transplant. As Dr. Indu said, I'm sure most of your practices, if a patient is somewhere around the age group of say 30 to 50-year-old, and if you tell them that post-transplant 5 years is almost, you have a lifespan of almost about 60%. 5-year survival rate, you give them a 10-year survival rate of more than 40%. And if you tell them that they're going to live without oxygen immediate post-transplant, I'm sure you can convince most of your patient into getting a transplant done. I understand cost is a huge issue in India. And again, considering cost, it is ideal to convince a patient, or it is ideal to prime the patient for transplant, because they also get some time to arrange for their finances.
Absolutely.
And most importantly is putting the patient on a pulmonary rehab. So if you feel if the patient is already a candidate, as I said, there's a candidate selection and time of listing. So if a patient is already a candidate for transplant, it's ideal to put these patients on pulmonary rehab. Any patient who's going in for a transplant requires at least a minimum of 4 to 6 weeks of pulmonary rehab, which is extensive pulmonary rehab with nutrition support, emotional support. These are also required. And so if we are looking at all these factors, then early referral for transplant is the only way to give better transplant outcomes in India.
Absolutely. I think very comprehensively answered, because now, as you mentioned, okay, the referral criteria and the listing criteria. Now, in fact, when we look at our practice, almost 80 to 90% patients, when they come to us for the first time, they're already at the referral criteria, because their FECs are down, and walk desaturations are quite significant for these patients. I think the biggest barrier for all these patients is, one, the cost, and second is acceptability for this whole procedure. But when you insist that yes, it will improve your quality of life, quality of survival, that is something which needs to be stressed upon for these patients. And as our practice, we generally counsel them, all ILD patients we see, we counsel them for the first time itself that, okay, this is something which may be required. We'll see if we can avoid that, but this is something which may be required. And we see nowadays, our counselings have changed, and over a period of years, more and more patients are actually accepting transplant. Yes, Dr. Indu, you're muted.
Yeah, I would like to ask Dr. Aishwarya, what is that frailty score that you mentioned? Can you please explain?
So this is a score that we designed with we had like a cumulative frailty. Cumulative frailty is basically all functions, that is your liver functions, kidney functions, and also the patient's height, weight, and everything. And physical frailty, which is patient's physical strength, which is assessed in their pulmonary rehabs, along with emotional, their financial. So we consider all of this as frailty, and we come up with a frailty score. So when we assess this frailty score, pre-transplant for these patients, that is from the time of listing, and we assess the frailty immediate post-transplant, 3 months, 6 months, and 12 months. And we felt that the frailty scores will not improve. The frailty scores are already high pre-transplantation.
Thank you.
So what I want to insist here is, in India, as Dr. Samir was just saying, most patients who come to us are already candidates for transplant. And on top of it, we still continue to only try on different medical managements. Like even now we spoke upon, one or two or more antifibrotics. So at this point, if the patient is not at all on, say, pulmonary rehab, and if you're still talking to them about, thinking, even if we are not giving them the option of transplant, their frailty is really poor. And when they come to us, the muscle mass is really weak. They're not really mobilized. They're completely bedridden. And such patients, the transplant outcomes are going to be poor.
Absolutely. And I think this point which you just made, in fact, I wanted to have a discussion with Dr. Mehul on this, that, availability of these antifibrotics and, the whole criteria. Dr. Mehul, do you think that is impacting the timing of lung transplant referrals? Because, currently people just try to slog those lungs, those, end stage lungs with antifibrotics one after the other, and, just wait for that response. Do you feel that is actually impacting the referrals for lung transplant?
Yes. So if you have, as you said, if you have a patient who has fibrosis, some form of fibrosis on the CT, the physician or the chest physician will straight away go for an antifibrotic drug. I think there the criteria for referral should also be there. So if I am seeing a patient of a fibrotic ILD, whether it's IPF or non-IPF, the discussion of transplant should come in the first sitting itself. Okay, these are the treatment plans, these are the treatment options available, rehab, your nutrition. These are like it's like my SOP of all the ILD patient that should be mentioned. Yes, antifibrotic drugs is something which comes, pharmacotherapy is something which comes, and that leads to delay in fibrosis or delay for transplant referrals. But I think that should be the first step. Transplant discussion should happen at the first visit itself. But antifibrotics have made it difficult for patients to get a discussion going on for transplant. Second possibility is the availability of organs. Even if Indu and me sitting in Mumbai would refer to the two transplant units in Mumbai, the availability of organs is difficult. So early discussion should happen, and antifibrotic should not stop you from referring a patient for a transplant. In fact, if you see the criteria for listing what Dr. Aishwarya mentioned, a drop of FVC of 10% over a 6-month period. Our criteria for PPF is drop of FVC of more than 5% over a 6-month period. So usually these patients would probably fit the criteria for a transplant. So discussion should happen, and antifibrotic therapy should be started if there's an indication, but that should not stop the patient from having a discussion on transplant.
Absolutely. So, Dr. Indu, your comment?
Yeah, I want to add a negative point to this thing. So, like we see in severe COPD patients, some doctor might advise a lung volume reduction surgery. Patient might jump to another doctor, saying that, okay, the other doctor advised lung volume reduction surgery, and what can we do? And we optimize the treatment. Patients are better for many, many years. Same thing can happen in ILD also, PF ILDs. I mean, if the treatment was not optimized, like I said earlier, if you don't intensify the immunosuppressants in the autoimmune ILDs, and you don't add the antifibrotic on time, then probably we are leading to the downfall. And we might think that the lung transplant is required. We might start the discussions early. So when the patient comes to you, first we should think that the patient was given optimum steroids or not, whether immunosuppressants dose were optimal or not, whether antifibrotic was added too early or too late. So we have to cover all those aspects also before we start the discussion. So it's just a
yeah. No, absolutely agreed. Because as Dr. Mehul pointed out, the criteria for PPF is actually the criteria for transplant referral. So it always helps that you sit with the patient at the first visit only, give them all the options that we are going to do this, but please keep in mind there is transplant option also. We cannot rely solely on antifibrotics or whatever pharmacotherapy, and make sure those other supportive therapies are going on.
And I have a counterpoint to Dr. Indu. See, here I agree. Telling a patient who has not had a proper therapy to not undergo a lung volume reduction surgery works well in COPD. COPD can remain stable for a long time. PPF, we are losing time. Here is a problem. Secondly, it's a discussion. You are not sending the patient to the transplant unit. Please register the patient or list the patient. But patients, at least now post-COVID, have Google. They read the options and come, and I encourage that so that the discussion is pretty open. Okay, these are the options available. This is what needs to be done. The pharmacotherapy, the rehab, the vaccinations, oxygen needs to be done. Transplant is one option which may be now or maybe 6 months, 2 years, 3 years down the line. So the discussion should happen on the first day itself.
Absolutely.
Yeah. Agree to you, Mehul.
So, Sunil sir, now, coming on to this, and earlier also I asked, so is there any role of biomarkers, in diagnosing or maybe monitoring these progressive pulmonary fibrosis, and what's in the pipeline? Well, because we all are interested that, okay, if I can predict my patient is going to worsen, so, let me just go ahead and have the discussion for this transplant now only, or maybe put upfront antifibrotics.
Yeah, that's a very nice question, because very important also, because the discussion is going on when to have an antifibrotic as well as lung transplant also. How many set of IPF patients are going in for PPF, and what are the criteria, how to monitor, when to refer them, and when to subject them to lung transplantation. So biomarkers are very, very important in this context actually. Before I touch that, I really appreciate Aishwarya madam efforts to do rehab before going for a transplant. because even you do a transplant also without any poor performance, there won't be any much of the outcome results. So before transplantation, I do agree that a lot of stress should be done on the rehabilitation. That's very nice and fantastic. Coming to the question, this is what are new biomarkers in this ILD versus PPF and all. So basically, there are two biomarkers actually, KL6 as well as SPA. These are usually monitored for the progressive pulmonary fibrosis. I tell you, KL6 is a mucin-like primary expressed by the alveolar type 2 cells in the epithelial cells and bronchial epithelial cells. So it is definitely an indicator for the lung injury and the fibrosis. So automatically the epithelial cell proliferation and migration also. So what are the clinical significance of KL6 is KL6 correlates the disease severity definitely and progression in the ILD also. So including the IPF. So higher KL6 levels are associated with a poorer prognosis, no doubt, and increased mortality also. But serial KL6 levels of monitoring is very, very important. But how often you do that, it depends on the geographical area as well as how fast the patient is developing the decline of physiological variations and all. So other one is around surfactant protein A. So the KL6 is usually indicates the fibrosis indicator. And other one is surfactant protein A, which indicates alveolar damage. It is also produced by the alveolar type 2 cells actually. It plays a very crucial role in the immune dependent surfactant. So it is also elevated in case of a PPF and lung injury also. So it indicates higher levels indicates worsening of lung function. So these are the basic two tools how we monitor the progression of the disease inside the lung and more scientifically also, so that we can direct the patient onto the next line of therapy, suppose like the immunotherapy, therapy or lung transplant and all. So recently there have been other new biomarkers like surfactant protein B also in 2024 study. The heightened levels of surfactant B in serum extracellular vesicles could predict ILD more promisingly and more effectively than the other two biomarkers. That's it.
Are these available in India? And
in some of the
routinely
centers,
available or not?
in some of the centers they are available, sir, but not everywhere, I suppose. But the rapid use of these biomarkers will definitely improve the availability across India, I suppose.
Right. I think
Yeah.
so. The point is that yes, there are biomarkers, there are new things in the pipeline when it comes to diagnosis, but so far, because the specificity is questionable, that is why we cannot rely on these solely. Plus, availability is also something which is questionable. So yes, this is something definitely a space to watch out for, and maybe in future we can predict more accurately which patients are going to progress, which ones are not. With that, Dr. Indu, we have been talking about rehabilitation. So, what are various supportive care strategies for improving the quality of life in these progressive pulmonary fibrosis patients?
Sure. Interesting topic again. I think pulmonary rehab discussion should be initiated immediately once you start seeing the disease progression and exercise intolerance. It has shown that the pulmonary rehab improves the quality of life and it also enables the daily activities of the patient. Also, at the same time, you should address the comorbidities also, like anxiety, depression. There are other comorbidities like sugars which are going up. OSA is there, pH, GERD. So you have to address those comorbidities. You have to think about ambulatory oxygen in the patients who are very, very breathless. And there is a significant drop in the 6-minute walk. Plus, you have to also address the acute exacerbations with the NIV support. That is one thing. You have to address the patient's perspectives as well as personal goals. I feel many a times we don't discuss the patient regarding their personal goals. There's this one patient who told me they want to travel actually. Can you imagine, the plight of the person who just wants to travel? He is on oxygen, he or she is on oxygen, everything is in place, and they just want to travel, but they don't discuss with either. The family restricts them or they are not able to ask to the doctor. So I feel that is one important thing which we should address. And Pulmonary vaccinations, again, one thing should be given. Flu and pneumococcal vaccination on time, it should be given. And the pulmonary rehab course should be at least, initial course should be about 4 to 12 weeks at least. Yeah. You're muted.
I'm so sorry. So yes, great role. In fact, Dr. Mehul's slide was pretty comprehensive on that, and he really explained that well. You have so many factors. Is there any adverse effects from some of the medications? Is there a GRD component? Is there a sleep apnea component? Have you addressed those cardiovascular comorbidities properly or not? Is there some fluid overload or not? So once you do all of that, the patient himself or herself starts feeling much better. And second thing is rehabilitation, which definitely should be made standard of care. And it's a little disheartening that there's not much rehabilitation going on in the country, despite all the guidelines suggesting that yes, rehab works, level A evidence, but still we do not have, and patients do not have access. Plus, even the providers do not have much acceptance or rather awareness about these programs. So I think once we do all of these things, definitely it helps.
Yeah. I think pulmonary rehab facilities are available, but again, in our country, financial constraint, because of that, patients don't go. So I feel tele-rehab works well. Patients are very, very happy after 4 weeks of rehab.
Absolutely.
They actually come and thank us, we are all good and happy with the tele-rehab which is going on. There are other patients who are sitting in the group. And so they enjoy the group of the same ILD patients. And I feel even if the facility is not available, the doctor should spend a little time in the follow-up about and train them regarding muscle strengthening exercises, deep breathing, breath holding, incentive spirometer. Or you can train your staff to kind of go about it in the follow-up visits. So it becomes easier.
Absolutely. So Dr. Shikha, now multidisciplinary care. So do you feel, multidisciplinary care teams can enhance the management and outcomes of PPF patients, and should it be made standard of care for all patients? Your comments, please, on this.
Yeah, definitely, Sameer. Like any other ILD, definitely multidisciplinary care teams will definitely enhance the management and definitely the overall benefit as well. So let's start from the beginning. When it comes to the diagnosis, the team of radiologists, pathologists together. So when it comes to the treatment, so when we are discussing about the non-fibrotic ILDs progressing to PPF, we are dealing with certain kind of CTD ILDs where you need the help of rheumatologist. We are discussing about the immunosuppressants, steroids, or any kind of a second line immunosuppressant. So you need the whole team for the better treatment, for better follow-up. That is always there. And also, this is the whole team can definitely help us to better tackle the disease severity, the comorbidities. The patient can have multiple comorbidities, whether it's a pulmonary hypertension, whether it's a GERD, or any other comorbidity. The multiple doctors can definitely help in a better treatment. As Dr. Indu has also mentioned about the pulmonary rehabilitation, which also come as a part of a multidisciplinary. So pulmonary rehabilitation, timely start of the pulmonary rehabilitation can improve the functional status and better outcomes in the patients. And also the listing for the transplantations. So PPF patients, if we list the patients, we build the relation with the transplant team, we can always help in the I think so the overall better management of a PPF patient. Yes, it should be made a standard of care for all the patients of PPF.
No, I couldn't agree more, because we do have this a strong MDD in place wherein not just one but at least 5 pulmonologists sit together.
Right.
2 radiologists, 2 pathologists, rheumatologists, and our physiotherapist, and the perspectives that each one brings to the table, and the questions that come up. It's truly phenomenal, and you can see that yes, as a standalone person, you may be thinking in one line, and that thought process may get changed entirely also for the benefit of the patient. So yes, it does improve, and I feel and I see that most of the centers now have an active MDD going on. And I strongly urge practitioners who do not currently engage in multidisciplinary discussions, please do that. Please find colleagues and please make it a point to have those MDDs in place.
Can I just add one more point? Like as Dr. Shikha rightly said, to establish a bridge between the treating pulmonologist and the transplant physician. As this is actually extremely important. So say, for example, when a patient's referred to me for transplant by a primary pulmonologist, make sure the medical management is still taken care of only by the primary pulmonologist. And what I am doing here is just working this up, make patient up for transplant. And probably our team gets involved with pulmonary rehab, and we are listed. And I feel throughout the entire journey, the primary pulmonologist should always be involved, and even during the post-transplant phase. And the one most important thing is even with the transplant listing, it's always an MDT for us. It's an MDT which involves a gastroenterologist when the patient had a severe gastric reflux, or a scleroderma patient. We do all sort of pH manometries and gastric reflex studies. So he's involved. The patient's emotional support is extremely important. So there is always a psychiatrist involved. There is always patients, the pulmonary rehab team is involved. As I said, our rehab, there should be a minimum of 4 to 6 weeks of rehab. So rehab team is involved, and the transplant physician, the primary pulmonologist, as well as the cardiothoracic team. So it is definitely a complete MDT approach. Even if not listed for transplant, also it is a proper MDT approach when it comes to ILDs.
Oh, absolutely. So I think that just strengthens the view that each and every phase of patient's life cycle, and MDD is a must, especially if you're dealing with an ILD patient, be it diagnosis, be it treatment, be it transplant. So I think, Dr. Indu, you want to mention something out here?
Yeah, so the most part of the country basically is the private sector, and you all are very lucky that you all have MDD in place. But I would like to add that people who don't have MDD, I think just call your radiologist over the phone when you receive the reports. We get various types of reports, various subsets of the ILDs are reported. And when we talk to the senior person, when we are not thinking about a particular, so I think we should have a little bit of knowledge about the HRCT also. Get trained in HRCT, get trained in PFT. A little bit of understanding about PFT, DLCO is important. This is for the non-pulmonologists who are actually treating ILDs.
Yeah, I have a point to add to Dr. Indu's thing only. If we are in private practice, post-COVID, online MDD is possible. If you are a group of 4 or 5 or 10 or 50 pulmonologists having a group, discussing a case there is like an MDD. So
Exactly.
keep an open mind, discuss your cases. Sometimes a fresh set of eyes sitting in your private clinic, somebody is giving a fresh perspective, might help the patient. And as she said, rightly said, pick up a phone call, speak to the radiologist. That is the best way.
And we have MDD in place in the WhatsApp group.
Exactly.
So even in my
Yeah.
hospital, I don't have that MDD whole team, but this is how we discuss. Like we call the radiologists at time if we have some kind of a difficulty. So, but we don't have a kind of a conference that we all sit together and discuss a case. So that's not there in my hospital as well.
Samir is lucky.
I think it because we also took quite an effort, to get everyone every Wednesday morning 8:30 sharp over there in that particular room, and the major challenge is getting those 4 cases of ILD over there every Wednesday consistently. So yes, my team has been working pretty hard for that, but yes, it is in place.
Yeah.
Super.
And finally, Dr. Aishwarya, any role of genetic testing for identification of PPF phenotype or likely patients who may progress? Just the final question.
As Dr. Sunil sir said, genetic testing is still not very specific, and we don't know how many places actually do genetic testings for IPF. But say if you're looking into a familial disposition here, familial pulmonary fibrosis, in such cases, yes, genetic testing would play a role. And MUC5B gene protein expression is closely associated with PPF. And also only 20 to 30% of the patients having a family predisposition of pulmonary fibrosis have genetic expression itself. So that itself says, I'm not sure how much of weightage it would add, but say if the patient had previous a family history, or if the patient is having features of either familial or personal, that is cryptogenic cirrhosis, aplastic anemias, or premature graying, or issues like that, you could look for short telomere syndrome genes. I mean, because that also adds to the prognostication of the disease. Patients with short telomere syndrome genes have very poor prognosis even with medical management, and even such patients when transplanted, when put on immunosuppressants, they react very adversely. So for such cases, yes, genetic testings would be helpful.
Could you also shed some light that are these widely available, especially the short telomeres, which have significant prognostic implications?
Honestly, I really don't know much about it. So, I mean, if anybody in the panel is doing these tests,
the thing is that regarding your previous questions, I mean, actually, these biomarkers are available in some part of the South India. Like Mysore, there is a JSS Medical College. They are doing research on KL6 as well as PEA also now. And one company, Fujiburo, they're supplying that one. And likewise, there are multidisciplinary units there in the medical college also who are actively engaged in ICMR project, where the genetic testing is also going on there. I think it is still pipeline. I suppose Aishwarya will update you later on this part of the thing.
I think KEM in Mumbai does the genetic testing. If I'm not Mehul, if you know by any chance, right?
Never referred a patient, but yeah, they do.
But I've seen,
yeah, for PFILDs, I'm not sure, but they do. They do for.
I think so. AIMS Delhi is also doing.
Okay, I think possibly we can just find out and put it across somewhere, because even I'm clueless at this point of time if we do it or not.
Yeah.
So I think that's it for my questions. We have some audience questions also, which we'll quickly take. Most of the audience questions is covered, but I think we'll just go ahead. So Dr. Mehul, Vinny from Kerala is asking, what is the prevalence of PPF currently?
In all your patients, as I mentioned in my slide, who have come to you with ILDs, 13 to 40% would probably develop PPF. So keep an open eye for all those people.
Right. Dr. Sunil, so Dr. Murli from Andhra Pradesh, he is asking that do surfactants have any role in treatment of pulmonary fibrosis?
No, actually, the surfactant proteins are the indicator, biomarker indicator for the damage of the alveoli, as well as the alveolar epithelial cell damage and injury, and the fibrosis progression. Actually, surfactant as per se, usually we use in case of ARDS and all. So any patient going in for an acute respiratory failure, something like that, maybe we can use it, Dr. Murli, sir.
Yeah, so there's no clear-cut recommendation. They have tried, but again, what they found was a very temporary relief, so it's not really recommended. I think we already answered this question from Shehbaz. Which MUC gene has the strongest association? So I think Dr. Aishwarya just answered. MUC5B is the gene which has an association. Where is it done? I currently do not know about it. This is an interesting question by Dr. Amar. Dr. Indu, how to counsel the patients of IPF regarding mortality rates and short lifespan after diagnosis?
Very interesting question. I love this topic actually, about the advanced lung diseases. This is actually IPF, which is an advanced lung disease. I can put it like that. You don't talk about mortality per se, but you don't even talk about short lifespan. You just basically you kind of do the spirometries, you do the HRCTs, 1 or 2 spirometries, and you see if the disease is progressing very, very fast. You tell the patient and the relatives together that this is a progressive disease which progresses very fast. And you have to also tell the patient, you have to discuss about the ventilator issues, that the patient should not be put on the ventilator because it's an irreversible disease. So that aspect of the IPF, mostly it is never covered. And these patients, if they go on the ventilator, then they get dependent on the ventilator. So that aspect should be covered along with the family members, that in case of any untoward breathlessness which increases, in case the acute exacerbation increases, which is not a reversible problem. In case of reversible problem, like an infection or something, yes, you can put it and then wean off. but then irreversible, which is IPF, mechanical ventilator is not recommended. So those things I think should be covered.
Yeah. So Shaibaz from Navi Mumbai asked that what is the extent of fibrosis on CT scan in a case of RA-ILD that poses a risk for PPF? So Dr. Shikha?
So I don't think so. There is something like an extent that, but probably the extent, I don't know, that there is some kind of a, this thing that there should be that much of extent that can lead to, you can define it as a PPF.
Yeah,
I think more than 10% is
probably more than 20%. I feel like, I don't know.
More of a UIP pattern, I would say. It's a pattern which will be more important than the extent of fibrosis.
Yeah, extent, I don't think so. That
in the radiologist use this quantification of pulmonary fibrosis score, which is based on the quantity of GGOs, regulations put together.
So so what they say is the higher the fibrotic score on these calipers and otherwise also, and plus if you have a UIP pattern, that itself is a risk factor for, and RA itself is a risk factor for progression to PPF in certain cases. So yes, I think Dr. Mehul and Dr. Indu, you can answer best centers in Mumbai for lung transplant. I'll stay out of that.
Sorry, I didn't get the question.
Best centers in Mumbai for lung transplant
in Mumbai.
Okay. I think this global has a unit and we have Samir Garde, right, Mehul? Samir is running the transplant unit at
there are
global.
two transplant units. HN has started and Global Hospital Parel. They do. I would say currently, it's not about the best center, it's about sending the right case to the center.
Most probably earlier the better.
Earlier the better.
Earlier referral is the better, I suppose. Yeah.
Dr. Aishwarya, role of HRCT versus lung biopsy in worsening pulmonary fibrosis in spite of antifibrotics?
No, definitely not recommend a biopsy when the case is actually worsening. You can end up having a pneumothorax while doing a biopsy. Probably just go with, and also it's an invasive procedure. I don't think you can even plan on doing a biopsy on these patients. So I would definitely prefer doing a HRCT, which is less invasive at that point.
Yeah, in fact, HRCT can give you all the information that you require, whether the fibrosis is worsening or not, and your biopsy is not really going to add anything to your interpretation. Dr. Mehul, Mr. Manas from Mohanty asked, do you add steroids to PPF when symptoms are worsening?
It depends on why the symptoms are worsening. If it's an infective exacerbation, then no. If it's worsening due to a cardiovascular disease or something else, maybe no. Steroids, if it is more of an exacerbation, like an IPF exacerbation, probably there would be a role of steroids for short term.
Right. Dr. Shreyami Saha asks, what is the difference between PPF and PF-ILD? So I think it's just the one and the same thing.
Progressive, yeah.
Yeah. So then how to choose between the two antifibrotics? We've already covered this. Diagnostic criteria, I think we went through in detail. Okay. So here's an interesting question. I think we haven't covered this. So I think Dr. Sunil, sir, can you explain the pathophysiology? Can you explain how fibroblast activation leads to Rung-Lee modeling? And how does lavage contribute to diagnosis of ILD? And what are the cellular patterns indicative of specific forms of ILD?
Basically, it is a fibrosis because of the damage, actually. There is a alveolar cell, epithelial cells are going to get damaged because of the inflammation and fibrosis. There is a proliferation of fibroblast leading to irrecoverable injury, and leading to fibrosis, of course. It's a continuous process. So better we halt the process at the earliest with the treatment and all. So that is the reason why patients are going to have the fibrosis and all.
Yes.
It's epithelial and alveolar damage. Both are there in factor.
Absolutely. And Dr. Indu, role of lavage in diagnosis of ILDs?
Yeah, so if lavage is showing more than 10% of the lymphocyte, it goes in favor of the poorer prognosis.
So I think one of the major things in lavage is that, yes, with increased number of lymphocytes, it also means that, yes, it is possibly an inflammatory phenomena going on, and you should still consider those immunomodulators and see, how much of a mileage can you get out of those. So that's one of the major things. And yes,
Actually, in some of the
factors
studies
also.
Samir, in some of the studies of the antifibrotic agents, there was a comparative study of the bronchial alveolar lavage in terms of eosinophil response and all. That is how one of the way to establish whether the response to the antifibrotic.
Right, sir.
So as Dr. Indu has said, like lymphocytes, probably less than 20% in HP carries a very poor prognosis. So even in those cases also it's been done.
Correct.
Dr. Shikha, can you discuss, I think this we've already done, role of inflammation and immune responses in the disease? I think the whole discussion has been going on to this. Yes. So how do genetic and environmental factors contribute to the development of progressive pulmonary fibrosis? I think we just discussed the genetic factors and environmental, of course, ongoing inflammation. Yeah. So, Dr. Shikha, can you just shed some light on the contrasting mechanisms of action of two different antifibrotics? And what is the significance of a 6-minute walk test in assessing functional capacity of ILD patients?
Yes, 6-minute walk test basically tells about the that how much meters the patient can walk and can give us a good idea about the functional capacity of the patient. So if a patient is being progressing, then we can measure the distance, the 6-minute walk distance, and if the distance has been decreasing or patient is getting desaturated, so that means the disease is progressing and we have to really look into the patient's management. We might need to step up the treatment, or we might need to rule out all any other causes of things which you feel that has led to the decrease in the 6-minute walk distance. And what was the second question? Sorry.
The second question
the antifibrotics. So as we all know, we have two antifibrotics which are available. One is the nintedanib and one is the pirfenidone. Most of the studies in PPF has been done on nintedanib, though pirfenidone has also been shown to have a good role in improving the FVC. And nintedanib, we know that it is a tyrosine kinase inhibitors and therefore act as an antifibrotic. The pirfenidone role is not very clear that how does it manage. But yes, most of the studies are being done on nintedanib and it's being, I think, so more frequently used in PPF as compared to pirfenidone. But I feel that it's totally individualized thing that you feel if the patient's tolerance, the side effects, everything needs to be taken before you are prescribing antifibrotics.
So Dr. Aishwarya, Dr. Bhavya asks from Maharashtra, what are the most promising areas of research when it comes to PPF?
Most promising areas of research is, we just discussed, looks like the genetic
antifibrotics.
Yeah. Genetic testing, does it have a role, or antifibrotics? We spoke so much about it, two different types of antifibrotics. I think probably we can look into or more into pulmonary rehabilitation. How much is it going? Because that's something that not many centers in India have worked on. So that is probably something that we could focus on when it comes to area of research.
Yes, absolutely. I think they're trying to develop newer drugs, but most of the research at this point of time is going in diagnostics, genetics, mostly to identify these subsets early and refer them for appropriate transplant or antifibrotics early. So Dr. Mehul, Dr. Puneet asks from Delhi, can you discuss the potential role of stem cell therapy in treating ILDs or progressive fibrosis in general?
Currently, no evidence of a good role. Maybe you can try in some patients, though I have never referred a patient for stem cell. Sounds exciting, sounds promising, but I don't think it is having any role currently.
Yes, no, absolutely. So in fact, it has been around for almost 20 years, but not recommended. In fact, one of our patients also decided to give it a try before going for transplant. So, but yeah, not useful. So I think all the other questions we've already answered regarding MDDs and rehabilitation and everything. So, we don't have any further questions now. I think I'll just like the organizers to take over at this point of time. But yes, it was a lovely discussion. And I'm pretty sure everyone, all the audience members, everyone benefited from it. And, it's just a continuing topic, and you will see all these patients in your practice day in, day out. Make sure to have the right practices, the best practices, right from the diagnostic criteria to selecting the right medications, and just go for patient advocacy. Do not try to do certain things just because you have access to do the right thing. Have those MDDs in place, and yes, whenever you have transplant facilities available, or if not, there are multiple centers in the country which are doing, refer early. So I mean, that is the take home message from my end. I would like everyone to just have some.
And what a lovely moderation by you, Sameer. Great moderation. Thoroughly
so much.
enjoyed. Yes. Over
I
to
do
you.
agree. Yeah.
Thank you.
Thank you all. Thank you.
Thank you.